So we're going to go ahead and get started on reviewing for exam 3. So once again, split this into two parts. The first part will be hemoc or hematology and endocrine and some of the most common pathophysiological processes related to those two systems. So first, let's go with hemoc. So alterations in the hematological system. So how does the body, tissues, and organs survive? Well, if it isn't for blood, no oxygen would get to those tissues, and then, of course, they die. They cannot survive. So when we talk about pathophysiology related to blood, we really think about the quality of the different blood components. Some of the major players in the blood, these components, such as erythrocytes. So we know erythrocytes, we think about oxygenation, of course, because this is where hemoglobin is housed. So red blood cells are erythrocytes. They're really kind of structured to carry out their function. So in this case, they are a biconcave shape. So you can see up there in the corner how in the middle they kind of look like a donut, but they don't have the hole in it. Well, because of that shape, they're able to have an increased surface area versus volume ratio, which means that is allowing optimal gas exchange. And the gas exchange that we're talking about is between oxygen and carbon dioxide, right? The other thing that's kind of fascinating about these little guys is that they have the ability to have reversible deformity. What does that mean? Well, because they go through those little capillaries, so they kind of squish up and make themselves into little torpedoes, and they shoot through the capillaries. As soon as they come out of that little small space, they open back up. So those two structures, the way they're designed, helps in their functioning to do that appropriate gas exchange at that tissue level. So the next thing is hemoglobin. So why is hemoglobin so important? Well, it's because that's where the heme is, or where the iron is stored. So hemoglobin is once again all about that oxygen-carrying protein that's housed in the RBC. So you can see the normal values, like male is about 16 grams per deciliter and a female is around 14 grams per deciliter. Now, in your own facilities, that might be a little bit different, but overall, if you would see that on the exam, it's going to be very, very low. All right, so with hemoglobin, one of the big important things about hemoglobin is, of course, very dependent on nutritional intake. And we're actually going to be talking about some of the anemias and some of the most important vitamins, such as the B complexes, such as B6 and certainly B12. And when the body doesn't have enough of those, we're going to see what happens in anemia and the different kinds of anemias. The other thing about hemoglobin is the importance of iron. And so we have to make sure that our patients are getting enough iron. And we're actually going to talk about a certain kind of anemia, iron deficiency anemia, that is pretty common here in the United States. So the next thing we're going to talk about is leukocytes. So leukocytes, we've talked a lot about this when we talked about the inflammatory and infection processes back in exam 2. So we know leukocytes are, we sometimes just generally call them white blood cells. So we know that it defends against microorganisms that can cause infection, but they also remove debris, including dead or injured cells. What happens, though, in a pathological process is when the demand for mature neutrophils exceeds the supply. So what happens is the bone marrow begins to release immature neutrophils. Well, the good thing about this, as far from a clinician standpoint, as a provider, you can look at a WBC differential. And that's readily available if you order that, and you can actually see what happens. If you're suspecting an infection, for example, an appendicitis, and we'll talk about that when we get to GI, but you're suspecting an infection is going on, maybe they have a fever. We know those systemic signs of infection is a fever. They come in with a really high fever, blah, blah, blah. So you look at that WBC differential, and what you're going to see is something called BANDs, BANDS. BANDs are immature neutrophils. So now the body is really pumping out these neutrophils, yet they're still immature, so they're not going to be able to do as good a job of a mature one. But it's a great way for you to determine, look at all those bands, there's an infection going on. So we've kind of talked about the major players. So let's talk about anemia. So anemia really overall is a reduction in the total number of erythrocytes. We're going to talk about a special kind of anemia called aplastic anemia in just a minute. But let's stick right now to the kinds that have a total decrease in the total number of erythrocytes, and it can also be a decrease in the quality of the hemoglobin. So anemias really commonly result from something like impaired erythrocyte production. We know when we get to the renal system in exam 4, we're actually going to see how chronic kidney disease impacts and causes anemia in those patients. But it's really related to the kidney's inability to produce erythropoietin. Blood loss, this could either be acute or chronic, increased erythrocyte destruction, and any combination of those three factors. So let's talk about megaloblastic anemias. So with megaloblastic anemias, the cells are actually challenged to make DNA. We all know already how important DNA is, but it's interesting because RNA production continues. Because remember, DNA is in that nucleus, and that's what's being attacked. Versus RNA, really RNA production is out there in that cytoplasm, right? Well, the cytoplasm is just fine. But what ends up happening is the cells have slow maturing nuclei, that's just what I said, but have normal cytoplasm. Therefore, megaloblastic, megal means huge, large. Therefore, those nuclei become larger. They become mature enough, but do not become mature enough to actually have cell division. So what this means is that with that surveillance system, our surveillance system to check on those RBCs, it's really the macrophages, right? So what the body is sensing is that RBC is useless, right? Its membranes all messed up, whatever. So what it's going to do is it's going to prematurely remove that RBC from the circulation. So what ends up happening? Not enough RBCs, and the RBCs that are there really aren't quality. So what happens? Anemia, right? And one very special, more common, I would say, megaloblastic anemia is called pernicious anemia or B12 deficiency. So this is a great example of a megaloblastic anemia. But the principal disorder in PA, pernicious anemia, is an absence of that intrinsic factor. Intrinsic factor is secreted by the gastric parietal cells, and it actually makes a little complex with that vitamin B12, and that's what allows that B12 to actually be absorbed by the intestines. So without the intrinsic factor, the body does not have that B12, which is so important in the production of those RBCs. So what ends up happening, of course, is that megaloblastic appearance of the RBC. Now, what's associated with PA are the use of gastric acid blocking agents. You've all heard of the purple pill, right? Nexium. But that's one risk factor, particularly in our older adults, that you want to look at, because not only is the purple pill given out like candy because of GERD, but also because of age. So those parietal cells are not secreting that intrinsic factor like it should be. So it's probably recommended if you have an elderly patient as a provider, they come in. The thing about the signs and symptoms of PA, it can be it's old age, right? They're starting to fall. Their equilibrium's off. They're getting a little dementia. You know, something you want to think about is checking that B12 level, because that could be an easy fix, because you could just give it IM, intramuscularly once a month, or by mouth, maybe increase their dose that way. So when you have an elderly adult, you may want to use one of those, when you're trying to figure out, okay, their dementia is getting worse, they're falling, whatever. That could be a really simple, inexpensive way and a quick fix. All right. So some of those signs and symptoms, like I had already said, a lot of times they're ignored. They're increased in infections, mood swings, and some of those GI upsets. And of course, you can see the tongue. The tongue is, and this is kind of common with all the different anemias, but you can see on the corner of that person's mouth, a lot of times they'll get those kind of white flaky things, and they're a little bit reddened. Also, look at the tongue. The tongue can tell you a lot about somebody, but you see sort of that beefy red appearance. So next with the anemias, we're going to go to the other side, and we're going to look at microcytic hypochromic anemias. Okay, that's a fancy way of saying micro. They're going to be tiny now, and they're not going to have that nice, rich red color. And this is considered probably the most common is the IDA, which is iron deficiency anemia. So iron deficiency anemia is usually by an inadequate intake of iron, of course, or it could be an excessive blood loss. The most common cause of IDA in developed countries, here in the United States, whatever, is usually pregnancy as well as chronic blood loss. So that makes sense. Early symptoms are very nonspecific: fatigue, weakness, a little bit of shortness of breath. But look at some of those signs and symptoms on the PowerPoint here. If you look at someone's eyes, you pull down and you look inside the conjunctiva there, and it's very pale. You can also see, once again, those kind of sores around the mouth. And look at the nail beds. Looking at those nails, you can see that they split easily. You can see those little white lines. All three of those are really good signs and symptoms. The other thing is you'll see that females or males, but particularly we like to chew on ice. If they continue to chew on ice, that might be a sign of anemia. It was with me. I couldn't get enough ice, but before I even realized I have iron deficiency anemia, my hemoglobin was all the way down to 9. And then the only reason why I sought any kind of care was not because I was tired, because, I worked full time, gone to school full time, children, blah, blah, blah. Of course I'm going to be tired, right? It wasn't that. It was because my heart started having palpitations. But I could remember, oh my God, my mouth was always so dry. So sometimes just asking simple questions like that intake of excessive amounts of ice, always thirsty, that kind of thing. So the thing about IDA is it really is not much loss of blood per day. It could be about 2 to 4 mils per day. With women, probably the number one cause is menorrhagia, which is excessive menstrual bleeding. And with males, though, it's a little bit different. Usually you really want to look for a source of bleeding. Sometimes it might be ulcer, gastric ulcer, hemorrhoids might cause that. But the other thing it could be is some type of cancer. So make sure they get that colonoscopy, and you could easily save a life. So early symptoms, like I said, most of the time they're just ignored until they get pretty bad. Like with myself, it wasn't until I started having chest pain and heart palpitations. Good Lord. Anyway, hemoglobin of 9. I must have really felt bad. So just be aware of iron deficiency anemia, and very, very easy to look at. Just look at their eyes, the conjunctiva. All right, next is some of the other types of anemia. When we think about aplastic anemia, it's a critical condition, and this is actually mostly caused, the main cause, I should say, is by an autoimmune disease against hemopoiesis. And this is caused by those cytotoxic T cells. But it's characterized by pancytopenia. So when I say pan, that means all of them, all right? All the different cells. So that's erythrocytes, leukocytes, and thrombocytes. So all three of those are affected. Excuse me. So what ends up happening is it suppresses the ability of the bone marrow to produce adequate amounts of those three blood components. The other thing about aplastic anemia, we know that the main cause is an autoimmune disease, but just fascinating, and you don't have to memorize this by any means, but I just want you to be aware as providers that there's actually medications that can cause a patient to go into an aplastic anemia process. And if you looked at that table on page 939 of your textbook, once again, do not memorize those, but I thought it was really interesting. Some of the major medications people take, aspirin was on there, Motrin, Heparin, Tylenol. I mean, those are everyday medications. So when you're trying to rule out the cause, you may make sure, as I know you will, make sure that you know what those patients are taking. The other kind of anemia called anemia of chronic disease. So this is something we really watch in our hospitalized patients. But it's also when you're in a clinic, you have patients with chronic illnesses. And so you want to watch. And as we get into the different systems, such as pulmonary, renal, that'll be an exam 4. But those patients had a very high risk for anemia. And that certainly does make sense. So some of the combinations of the potential for anemia is decreased erythrocyte lifespan. What do I mean by that? Well, for example, I don't want to give you too much information because I want you to come back for exam 4. But for example, with COPD, those patients, their body lives in an acidotic state, right? Well, those RBCs, so that's kind of a toxic environment for them. They like that perfect 7.35 to 7.45, just like the rest of the body does. So their lifespan isn't going to be as long. So once again, you're going to see that increased risk for anemia. The other kinds of causes could be suppressed production of erythropoietin. And I've already talked about, chronic kidney failure. They're not producing that erythropoietin very well, or not at all. Other things such as altered iron metabolism and iron sequestration in macrophages. What does that mean? That's people that are not getting the iron that they need. A lot of times we see patients with that are suffering from alcoholism. Once again, they're not having that right nutrition. So anemia of chronic diseases, that's what we're talking about, those other comorbidities going on with those patients. So that's why we watch that hemoglobin. Post-hemorrhagic anemia, they lost blood, right? So that one's pretty straightforward, but it's a reduction in tissue oxygenation because we don't have the little guys going with oxygen, those RBCs. There's not enough of them to perfuse the tissues. So what ends up happening is the body senses, don't have enough RBCs. Let's start pumping them out. Once again, they're going to be immature. So they're not going to have that maturity to do their function correctly. However, once again, as a provider, you can watch the reticulocyte count. Reticulocytes are just immature RBCs. And really, after about 7 days, you're going to see a bump up in those reticulocytes, even up to 10 to 15%. That's good, though. You know that body is working now to get those RBCs back up to where they need to be. Most of the time, it's only about 1%. Okay, so next we're going to look at, excuse me, we're going to look at the Hodgkin's lymphoma. So lymphoma is the most common blood cancer in the United States. We're going to really focus just on Hodgkin's lymphoma. And this is a malignant lymphoma. It's characterized by a progression from one group of lymph nodes to another. So the development of some of the signs and symptoms, one of the hallmark signs is something called the Reed Sternberg cell. And you can see that up there in the corner, how big and ugly they are. That is definitely going to be indicative of Hodgkin's lymphoma. But something else that is going to differentiate between non-Hodgkin's and Hodgkin's is the fact that with the Hodgkin's, look at this picture down here. I know that's pretty exaggerated, but like when you're taking the exam, I guarantee you're going to remember that picture. But anyway, what a lot of times they'll come in with not only the idea that they're fatigued, but like I said, fatigue is so, what's the word, subjective, right? But what they will come in with is they're going to start feeling those enlarged, painless lymph nodes in the neck. That is often the very first sign of Hodgkin's lymphoma. So next, let's talk about a few more of the blood dyscrasias. Heparin. We give heparin like it's candy, right? So this has been on the upswing. Depending on what reference you look at, HIT has actually, heparin-induced thrombocytopenia, HIT, has actually increased. Some information, the CDC says up to 8% now. Others you'll see 4%. So let's go 4 to 8% of patients that actually get HIT. So HIT, it's an actual immune-mediated adverse reaction. It's a drug reaction caused by IgG. And you can see this picture of what HIT looks like. But that's an outward sign of it. So it's that sloughing of the skin. And actually, this was a couple semesters ago, but I always like to use this example is, so I was with a student and we were walking a patient and the skin literally kind of started flaking off and falling off onto the floor. It was pretty nasty. But anyway, it kind of flipped the poor student out. But I just said, no, it's all right. Let's just clean it up. It's all good. But anyway, so the hallmark of HIT is, as nurses, we kind of have a sick sense of humor, but it is what it is. Anyway, the hallmark of HIT is thrombocytopenia. So I know you're watching that PTT, right? Making sure the heparin's therapeutic, not too high, not too low. But something else you should be watching are platelets, because the hallmark sign of HIT is actually you'll see a decrease of approximately 50% in the platelet count, right? So what ends up happening, and this is kind of interesting, but that immunocomplex, it actually sort of has a binding between the platelets, right, and the antibody. So it makes these little microparticles. And so at first you're thinking, wait a minute, with a decrease in platelets, why are we worried about a thrombosis? Because that combination of that antibody and that little platelet that it's going against, it makes little particles. And those little particles will begin to clump or aggregate. And what does that make? A thrombus. So what we watch for now is venous thrombosis is the most common. So they're very, very high risk of a venous thrombosis on the venous side, but also we're concerned about the arterial side. So the arterial thrombosis, and in this case, we could see, if it blocks the lower extremities, cause acute limb ischemia. But I'll tell you something else we're very concerned about is that thrombus breaking loose into an emboli and landing where? In the brain, stroke, myocardial infarction. So this can be, the sequela of HIT can be very, very dangerous for our patients. So next time you have a patient on heparin, you also want to watch those platelets. And what do? Stop the heparin. Okay, next one is DIC, and I promised we would come back to this when we were in exam 2. So we're going to move forward and talk about it just at a little bit more depth, but it's called disseminated intravascular coagulation, DIC. It's a very interesting pathological process. But first, disseminated clotting may lead to blockage of blood flow to organs, resulting in multiple organ failure. Sepsis is the most common condition associated with DIC, and in particular, the gram-negative bacteria. So what happens is that first, thrombosis is generalized and widespread. Remember, at a local level, go back to your inflammation process, but at a local level, the coagulation cascade is wonderful, right? You cut your finger, everybody comes into play there, the coagulation prevents you from bleeding to death. But now think about this in a systemic view. The entire body now is going through that same process. So at first, what ends up happening is that all the clotting factors, the platelets, everything is being consumed. So at first, there's all that overall clotting. But as those are being used up, now there's nothing left. And so what ends up happening is hemorrhage. So you're thinking, at first you'll see those little minor signs, like maybe they have an IV, and you'll start seeing a little seeping of blood. Maybe they got a central line. You're starting to see that blood, maybe a little blood in the urine, those kind of things. Those could be the sign that DIC is actually ensuing. So really, it's extensive clotting, but they're consumed. So those clotting factors and platelets are now consumed. Nothing left to stop any bleeding, and now you end up seeing that widespread hemorrhage. So now we're going to go on to hormones. Love hormones. So first of all, when we think about hormones, it's probably best to think about, so what do they do? Well, first of all, hormones, they have a specific rate and rhythm of secretion. So there's kind of three basic patterns, circadian or diurnal patterns. We talked about circadian rhythm when we talked about sleep deprivation, and we know what happens with sleep deprivation, right? Cortisol is the heavy hitter there, and we know all the potential pathological processes that can come with that. In addition, there's something called pulsatile or cyclic patterns. A good example of this is insulin, right? Insulin, for example, when you're ready to eat, insulin starts becoming produced, right? And then, of course, the next one is patterns that depend on levels of circulating substrates. So we're going to talk about some of those, for example, calcium, sodium, potassium, or even hormones themselves can trigger other hormones to be produced. Hormones operate within a very important feedback system. It's either positive or negative, and of course that is going to be very important when we talk about some of the alterations of these different hormones, as well as their functioning organs such as thyroid, pituitary. We're going to talk about parathyroid, and of course the adrenals. The hormones also affect only cells with appropriate receptors. A really good example of this is insulin, for example. So like with type 2, some of those patients have something called insulin resistance diabetes, right? That's a cause of type 2 diabetes. Well, insulin, when they go to the cell, they have a certain receptor there, correct? And they knock on that door, that little receptor, they knock on the door and they go into the cell. Well, in this case, sometimes that door is not working right. So the patient may have the insulin being produced, but they can't get it into the cell. And that's how some of the medications now for type 2 diabetes is actually developed and increases the cell sensitivity to insulin. So those are kind of the three big overarching foundational topics to help us get through now in discussing some of the alterations of the different hormone organs. So let's start with the anterior pituitary. So first of all, pituitary adenomas. So we know with the anterior pituitary, we know there's some pretty big important players that the anterior pituitary is responsible for. So, first of all, ACTH, right? That hormone that is secreted by the anterior pituitary, is very important for the secretion of cortisol. TSH, thyroid stimulating hormone, pretty important, right? Those two are big heavy hitters when we talk about the anterior pituitary. So let's talk about primary adenomas. They're usually very slow growing, and a lot of times are actually benign. But the problem with this is that the tissue of these tumors, they can secrete hormones, and they don't pay attention to that feedback mechanism. So they can just kind of pump out all they want, right? So they can just keep pumping out that TSH. So what happens with the thyroid? The thyroid's thinking, all right, we need some more thyroid hormone. And then you're going to see those signs and symptoms of hyperthyroidism, which we're going to talk about in just a minute. But anyway, the other thing which is fascinating is that paradoxical effect, because once again, go back to the brain, it's in a very small volt. So if they start having more pressure, right, it doesn't take much to start increasing the pressure within the brain. So that pressure produced by that tumor is associated with the decreased function of neighboring anterior pituitary cells. So you can also see a hyposecretion of other anterior pituitary cells. Another, which is one of the most common hormonal active pituitary adenomas, is something called prolactinoma. Prolactinoma is a hypersecretion of prolactin. So once again, when you went through that one chapter just on the normal endocrine system, if you reviewed what does prolactin do, it can help you understand what happens when there's too much. So we know that the physiologic actions of prolactin includes breast development during pregnancy, postpartum milk production, and it also suppresses ovarian function in nursing women. So the pituitary tumor that secretes prolactin, once again, it is the most common one that we come across in practice, but there's other conditions that can possibly cause it, such as medications. I can't stress enough how important it is for us to really make sure we know what medications that patient's on. Also, there's some other comorbidities that are associated with this, such as polycystic ovarian disease, which we're going to talk about for exam 4, renal failure or kidney failure, and like I said, once again, different kinds of medications, particularly those antipsychotic medications, are associated with too much production of prolactin. But some of the signs and symptoms, make sure that you certainly know this, and they make sense when you think about what prolactin does. And so what you're going to see is infertility. You're going to see milk production outside of, when women have a child, a baby, milk is automatically produced. This is not the case. It's random. Milk production begins. So galactorrhea, that is the medical term for milk production. Hirsutism. Hirsutism is increased facial hair in women. And in men, what can happen is some of those same things, but they usually come in with the complaint of erectile dysfunction, infertility, and osteopenia. Next is alterations of the posterior pituitary. Oh, go back. There we go. So diabetes insipidus. So we've certainly discussed this with the nervous system. So you can already tell, some of these hormones that we're talking about, we've already discussed, because the neural system and the endocrine system are very much interactive with each other. But once again, we're going to pull through some of those concepts again. And diabetes insipidus is really an alteration of that posterior pituitary. And when we think about ADH, once again, we think about water. So diabetes insipidus is a result of insufficient ADH, antidiuretic hormone. Now, DH must be distinguished from other polyuric states, and one of those is diabetes mellitus, and we're going to talk about that in and of itself here in just a minute. So the basic criteria for the diagnosis of DI is, of course, that urinary output of that 6 to 8 liters in a day's time. Now, there's two types of DI. In this round, in exam 3, we're really looking at neurogenic. Neurogenic, we discussed this when we talked about the nervous system, but this is the type of diabetes insipidus that we associate with traumatic brain injury, a tumor of the brain. Don't confuse this with nephrogenic. Nephro means kidney. All right, we're going to talk about nephrogenic when we talk about the renal system and really think about kidneys. So this is where the kidneys are not responsive to the ADH. There may be ADH out there, the kidneys are just ignoring it. All right, so those are the two different types. Don't get confused. We're really focusing on this time on that neurogenic. And then, of course, syndrome of inappropriate antidiuretic hormone. This is a review, pulling it through once again, but it really is, once again, all about that posterior pituitary. In this case, high levels of ADH in the absence of normal physiologic stimuli for its release. And what I mean by that is, it's kind of bizarre, but some of the tumors, like for example, when we talk about lung cancer, some of those tumors of the lung will produce ADH. Bizarre. But so for whatever reason, there's too much ADH that's being produced. So what are you going to see? Once again, you're going to see that hyponatremia. It's dilutional hyponatremia, and it's associated because there's too much fluid. You're also going to see that weight gain, but you're usually not going to see any edema. And so the severity, of course, is going to be determined on how fast or how slow that hyponatremia sets in. So let's move on to the thyroid gland. So first of all, know, what does the thyroid hormone do? Once you know what the thyroid hormone does, you can figure out what are going to be those signs and symptoms and the pathophysiology that goes along with not enough or too much. So when we think about the thyroid hormone, it controls the rate of metabolic processes. So I always think about the thyroid hormone as energy, right? Energy. Very important in neurologic function, cardiovascular, respiratory, normal muscle contractions, integrity of the skin, the hair, and the nails. So with hypothyroidism, not enough, one of the major causes is, of course, an autoimmune thyroiditis. It's called Hashimoto's disease. And it's a loss of thyroid tissue. Another cause is the loss of thyroid tissue after surgical or radioactive treatment. So sometimes treatment for hyperthyroidism can put the patient in a hypothyroid state, which makes sense. So look at some of these signs and symptoms, and it makes sense. So look at the picture up there of that person. Look at those eyes. Look how they're kind of sunken, and they got that puffy, boggy, big, what do you call those, bags under the eyes? Look at their hair. It's very coarse, kind of sparse. And so sometimes just looking at your patient, you can think, whoa, I need to get some some thyroid hormone levels here. All right. Also fatigue, reproductive, decreased libido, menorrhagia, which is, heavy blood flow, erectile dysfunction. Some of the other things, confusion, memory loss, lethargy. Once again, you want to test your older patients before you start thinking there's dementia going on. These are some of those basic foundational lab values you can run that are pretty inexpensive. Cardiovascular, though, I already told you it's all about energy and metabolism. Well, with the cardiovascular system, what you're going to see is a sinus brady. That's a simple or a medical term for a slow heart rate. Well, they're not getting that cardiac output, right? So they are going to feel that feelings of sluggish. The other thing is it's very important for ventilation, pulmonary. So they're going to complain of dyspnea, shortness of breath. And in severe cases, ventilatory problems. So they're going to have an increase in PaCO2, increase in that carbon dioxide, because the body's not able to breathe and get rid of it. So we know the thyroid hormone is very important in that normal hypoxic and hypercapnic drive. Other things, constipation. So when I really got to think about that thyroid hormone, don't have enough of it, wow, everything slows down, gets sluggish. Next is alterations, once again, in the thyroid. And in this case, we're thinking hyper. So energy, too much. Everything speeds up, right? But not good. Graves' disease, and we've talked about that once again when we talked about type 2 hypersensitivity reaction. And so it's really antibodies against the TSH receptor. So the gland results in hyperplasia of the gland. So sometimes you'll see that goiter, and it actually increases the synthesis of thyroid hormone. So that is one of the most common causes of hyperthyroidism. So now you're going to go the other direction. In this case, they're going to get that tachycardia. So their little heart, they're going to feel those palpitations. They're going to feel nervous, anxious, tremors. They're going to have weight loss, but they're not trying to lose weight. Also, their eyes, that exophthalmos, that's where they got that those bulging eyes. Thank goodness, after it's treated, there is cosmetic surgery, and insurance will pay for that to remove that excess. It's like more deposits of fat in there, and they can remove that, and insurance will pay for that. Okay, so let's go to the parathyroid. So the parathyroid gland, we really discussed this at length back in exam 1, but let's pull it through now. So alterations in parathyroid gland, hypoparathyroidism. That is the most common that you're going to see. And one of the main causes of hypoparathyroidism is after thyroid surgery, because there's they look like 4 little pellets that are on the thyroid gland, and those can be inadvertently removed. And so that puts the patient in a hypothyroid state. But go back and let's do just a quick review on calcium and phosphate. We know they're in perfect balance, right? And calcium and phosphate is actually mainly regulated by the parathyroid hormone. So when the body senses a decreased calcium level, PTH goes out there and begins what we call that osteoclastic activity. They're going to start tearing down bone. Oh my gosh, so you're thinking, well, that's not good, right? Because now the patient over time can develop osteoporosis. The body doesn't care about those bones. They care about the heart. And when we think about calcium, we know the major role of calcium is what? Cardiac action potential. It also helps with that pacemaker automaticity of the cardiac cycle. So very important. So the body wants to protect that heart at all costs. Who cares about bones? Other things, so the reverse is when there's increased calcium levels, it's going to suppress secretion of PTH. So you can see the importance. So if there's not enough PTH, right, you're going to see that imbalance of calcium, and then you're going to see the signs and symptoms of the calcium, not enough calcium in the body. So hypoparathyroidism, abnormal lows of PTH, and most commonly caused by the damage to the parathyroid glands during thyroid surgery or possibly inadvertent removal. Now let's go into the big one. You will see this in your practice, I guarantee it. But let's talk about some of the I would say acute complications. So some of the acute complications, let's start with DKA, diabetes ketoacidosis. The number one cause is usually infection. We know what happens during infection, right? It's the body kind of goes into that fight or flight response. It needs to fight that infection. So what happens, how we fight that is an increase in glucose, right? So, for example, a patient came in with DKA. She had been a known type 1 diabetic for quite some time. And it's kind of like, she'd always been, adherent to her treatment. So the first thing you want to do is let's rule out an infection. And sure enough, on the inner aspect of her right thigh was this huge pus-filled abscess. Nasty, right? But before we could treat that, you got to get them out of that diabetic ketoacidotic state, right? Okay, the other thing is a newly diabetic, sometimes DKA is the first sign before they even know they have it. And then, of course, we all know non-adherence to diabetic treatment. But what happens is there's polyuria, dehydration, and that's a result of that osmotic diuresis associated with that hyperglycemia. The urine, there is a threshold for glucose, so there is some glucose pouring out, trying to rid the body of that excessive glucose. But you have to remember, the body, that cell is not getting glucose, even though there's tons of it out there in the circulation. That's because there's no insulin to open the door and let the glucose in, right? So the cells keep sending out this message, we're starving, give us some glucose. And so the counter-regulatory hormones start kicking in. So you get your growth hormone, you get your cortisol, you get your catecholamines. They're all just pumping out this glucose. And so that's why these patients, they come in with these 900 plus glucose levels. Yet they don't have the insulin to get that glucose into the cell. So what ends up happening is it starts tearing down protein and fat, and there you see that ketosis. Now, in the hospital setting, we really don't check urine for ketones anymore. We have much more sophisticated ways of monitoring that glucose and that anion gap that we had talked about. But at home, we still teach our patients to check for ketones because that's one of the signs that they are starting to burn other things than glucose, fat, for example. So when we see this patient come in, what do we see? Well, we're going to see that hyperventilation. We're going to see that deep, rapid respirations. That's a sign, but it's also a good thing because it's compensatory. And so you're going to see, if you do ABGs, you may run one ABG, and you're going to see that, oh boy, that pH. Okay, so it's compensated, they're hanging in there, but you're going to see a very low PaCO2 because they're blowing off acid. The body's going to get rid of acid any way they can. And an easy way for the body to try and do that is, let's hyperventilate. Let's get rid of that CO2, that acid, any way we can. So with diabetes mellitus, you're going to see those signs and symptoms. You're going to see that ketonuria. You're going to see nausea. You may even see vomiting because, once again, the body's trying to get rid of that acid any way it can. That triggers the patient to think, oh, I better not take my insulin. So it just perpetuates the whole mess. But anyway, the other thing is pain, the abdominal pain, not sure why. And then, of course, thirst and polyuria. So once again, it's that osmotic diuresis that causes that polyuria and that very, very dangerous dehydration to the point of hypovolemic shock. So the other side of the coin, so we know with diabetic ketoacidosis, we know that's pretty common with type 1. So this we're going to talk about that's more common with type 2, because with hyperosmolar, hyperglycemic, non-ketotic syndrome, HHNKS, or hyperglycemic hyperosmolar state, either one is fine. It is still a life-threatening emergency. There used to be a very high rate of mortality with this because it was mainly with our older population, but we know now with obesity, the problem of the epidemic of obesity, we know now that young people can also have type 2, but still with our older population, high mortality rate because of the coexistence of other diseases, of course. But with this, you don't see that profound insulin deficiency, and therefore you don't see the ketosis. So usually, of course, you're going to do your good history. Are they type 2? Chances are it's going to be HHS versus non-diabetic. Versus diabetic ketoacidosis. So let's talk about a few more of the problems. Yes, there's many. So hypoglycemia. So hypoglycemia, with your diabetic, maybe their insulin is not well controlled yet. Maybe they're newly diagnosed and you're really challenging to get that perfect insulin dosage for your patient. But this can happen to you too. So you're in a 12-hour shift. You started at 7 a.m. It gets to be 3 p.m. You haven't eaten yet. Think about how you feel. You can't make a decent decision. Everything is overwhelming. You're getting a patient. You still need to do your medications on your other patient. Another patient's crashing, and you're just about ready to cry. You know what? That's that hypoglycemia. Stop, take your breaks, eat your protein bar, whatever. It's amazing how much or how important glucose is to you thinking. But think about how you feel. Irritable, jittery. There's that commercial, the Snickers commercial. I always give that as a good example because I know you'll remember it for the exam as well as your patients. That's the importance here. But you know, and this guy comes out and he's playing football and he's mean and he's pushing people around and somebody hands him a Snickers bar. He takes a big old bite and he turns into Betty White. Oh, everything's happy now. So hypoglycemia, we know we're healthy. We don't have diabetes, but hypoglycemia for us, we eat our Snickers or whatever and we're fine. But think about some of our patients. These are our diabetic patients that can actually go into a seizure and coma. So let's talk about the Somogyi effect versus the dawn phenomena. Why is this important? Particularly with our newly diagnosed diabetics. Sorry, I had to take a drink. So Somogyi effect versus dawn phenomena. The thing about this is it's probably pertinent when you have a newly diagnosed diabetic because you're really trying to find that perfect balance of their need and dosage of insulin. And you're thinking, well, they just sound alike. Well, they kind of do. But let me help you. So the Somogyi effect, it is hyperglycemia in the morning before they have breakfast. Dawn phenomena. It's hyperglycemia in the morning before breakfast. Well, shucks. What the heck is the difference here? The difference is with the Somogyi effect, all right, there's too much insulin, all right? So what happens is that insulin is taking hold. It's usually NPH. It takes hold around 2 a.m., okay? 2, 3 a.m. Plummets the glucose. So what does the body do? Oh my gosh, we need glucose. So those counter-regulatory hormones, that epinephrine, that cortisol, growth hormone, it starts pumping out glucose. So by the time the patient wakes up in the morning and takes their blood glucose, what do you think happens? Very high. So this is really caused by too much insulin. So let's go to the dawn phenomena. In this case, this is more of a natural phenomenon of the body because around 2 or 3 a.m., the body is sensing, oh, I got to get prepared. I'm going to start waking up. So it starts pumping out glucose. All right. So in this case, there's not enough insulin. Okay. So now that patient didn't have enough insulin. So all that glucose is starting to pile up. They wake up in the morning, their blood sugar's high. So before you just look at those morning glucose and go, oh my gosh, this is uncontrolled, I'm going to increase that insulin, you need to differentiate, wait a minute, what's going on here? So how do you do that? Well, you're going to need the help of your patient. So take that blood sugar at 2 o'clock in the morning. If it's really low, chances are they've got too much insulin. All right, so you want to back off. But at 2 a.m., if it's high, they don't have enough insulin. And so that's kind of the difference between those. So with Somogyi, let me just recap. With Somogyi, too much insulin. And you're going to see that 2 a.m. drop. Dawn phenomena at 2 a.m., too high, they don't have enough insulin. So once again, the difference is that insulin dosage. The good news is with some of the new insulin types out there, the kind that are the long acting, we don't see that as much, but it's mainly within those It's mainly within those newly diagnosed. So the other thing about blood glucose control is we're going to talk about micro and macro. So microvascular disease, think little capillaries. And where do we think of little capillaries? We think about those in the eye, right? So in the kidneys, things like that. So that's going to cause that damage to those, causing blindness in the eye, and end-stage renal failure or kidney failure is a better terminology. But it causes thickening of the capillary basement membrane, and therefore those endothelial cells begin to cause hyperplasia. And of course thrombosis. So that thickening decreases tissue perfusion, so those cells are not getting the nutrients they need, causing that damage. So how do we control our patients over time? We monitor their hemoglobin A1C, their glycosylated hemoglobin. That determines blood glucose control over 3 to 4 months. Our patients cannot tell fibs any longer. Oh, I do everything I'm supposed to. Really? But your hemoglobin A1C is over 9%. All right, and macrovascular, now think big. Think those big, large, and medium-sized arteries. And the thing is that it increases or accelerates atherosclerosis. What do we think about with atherosclerosis? They have an increased risk for infarction. When I talk about infarction, I mean myocardial infarction, which we're going to talk about here in just a little bit with our part 2, stroke, peripheral vascular disease. Much, much higher mortality rate with our patients with diabetes. And in fact, once again, some of those medications that they're taking is for heart protection, because we know of that increased risk for heart disease with our diabetic patients. The other thing is they don't feel the pain of a myocardial infarction like a normal person without diabetes. So we're almost finished. Alterations of the of adrenal function. So Addison's disease. I always think of Addison's disease. I want to add cortisol, aldosterone, right? Addison's disease. And so it's really a primary lack of cortisol or aldosterone. You already have a good foundation of what cortisol and aldosterone does. And so you can look at this laundry list of signs and symptoms of Addison's disease. I always add President Kennedy on here because people always thought, he was on the beach, but they really suspect that he might have had Addison's disease because he's got that beautiful tan year round. Well, we don't know. And that might just be a myth. But I think that really demonstrates how they have that tan. The other thing is, look at this pigmentation. You can see that it's vitiligo. Vitiligo are white patchy areas of depigmented skin. And so it can be quite problem with body image. The next thing is, I talked about the bronze colored skin, hypoglycemia. That makes sense. Think about what cortisol does. And of course, the big concern is when there's a crisis. So it really can cause that severe hypotension and literally vascular collapse. Now let's go to the other side of the coin, Cushing's disease. So this is that lack of that circadian secretion patterns of ACTH and therefore cortisol. But once again, think about that lack of cortisol as well as aldosterone. And when you think about that, you can see that you're going to have that weight gain. Sometimes they call it truncal obesity, moon face, buffalo hump, glucose intolerance, and of course, protein wasting. So a lot of times you're going to see kind of skinny arms. Here's a picture of that striae and that obesity. I don't think you'll forget that picture. There's certainly easy bruising. And so that, in this case, too much. So Addison's, got to add. Cushing's, too much. And then lastly, obesity and nutrition. It's not that this isn't important. I know they added a very short chapter on obesity and nutrition, which really further evidence of what a problem this has become. But actually, if you think about the systems that we cover, like we're going to go into cardiac here in a minute, but obesity is actually the 5th leading cause of death now in the United States. But you also have to remember, obesity is associated with the top 3 leading causes of death in the country, which is, of course, heart disease, type 2 diabetes, and cancer. So obesity is so interrelated and integrated into the different pathological processes and causes of these diseases. So I think this laundry list, we're pretty well covering all those diseases in and of themselves. But what you really need to take home here is overweight is defined as a BMI greater than 25 kilograms meter squared, and obesity is greater than 30. All right, so that's that, and thank you again, and certainly reach out if you have any questions.